Welcome back to the Talking Ketamine podcast. This is episode 77, Ketamine Eases Surgical Trauma.
We're looking at groundbreaking research on how low-dose ketamine during surgery can prevent severe post-operative flashbacks and emergence agitation in survivors of sexual trauma. For patients with PTSD, typical sedatives like midazolam can actually trigger distress and disorientation during recovery. Could an intentional shift to ketamine offer a safer, more compassionate way to wake up after surgery?
So just imagine for a second waking up from surgery, opening your eyes, and genuinely believing the doctors and nurses trying to heal you are actually trying to assault you.
Yeah, it's a terrifying thought.
You have, no idea you're even in a hospital. And for a massive portion of the population, this isn't some abstract nightmare. It's a documented, really terrifying medical phenomenon.
Right.
We're looking at the profound and honestly often hidden risks that being on an operating table poses for trauma survivors. And we're exploring how a tailored approach to anesthesia isn't just about, keeping you numb to physical pain anymore.
No, it's about protecting the brain.
Exactly. Protecting your brain and providing true psychological safety. Because for anyone who has experienced severe trauma, relinquishing total control in an operating room brings a very specific, visceral kind of dread to the surface.
It really does. And to understand why surgery acts as such a uniquely powerful stressor, we first have to kind of ground ourselves in the reality of who is actually lying on that operating table.
Right, the statistics.
Yeah, statistics are staggering. Research indicates that 1 in 4 females and 1 in 12 males report experiencing adult sexual assault or childhood sexual abuse.
Wow, 1 in 4.
1 in 4. And in the aftermath of those events, 1 in 3 women will develop post-traumatic stress disorder.
Which means, if you walk into any hospital right now, on any given day, a massive silent demographic of surgical patients is carrying this invisible weight, right?
Exactly.
They're walking into the OR already physiologically primed for a threat.
And for those patients, waking up from general anesthesia can be an incredibly volatile, dangerous process. There's actually a clinical term for this. It's called emergence agitation, or EA.
EA, okay.
Yeah. Instead of that peaceful, groggy transition from anesthesia back to normal waking consciousness that, you might expect, the patient wakes up in a state of absolute, unadulterated terror.
Oh, wow.
They're often severely confused, hyperactive, completely disoriented, and literally physically thrashing around the recovery room.
But calling it agitation almost feels like it minimizes what's actually happening, doesn't it?
It really does. It's a massive understatement.
Because it's not just confusion or waking up cranky. It's often a full-blown hallucinatory reenactment of the trauma itself.
Right.
There's a specific case study in the research that is just heartbreaking to read. It details a refugee who underwent surgery in an American hospital. And when she woke up from the anesthesia, she reacted to the medical staff with sheer panic, fully convinced they were trying to rape her.
Yeah, she was screaming at the doctors, terrified they were going to harm her and her family. Now, objectively, the staff were just trying to provide post-operative care.
Of course.
But her brain was completely disconnected from the reality of that hospital room. Her response was a visceral reenactment of a previous abduction, torture, and sexual assault she had survived back at her home country.
To go in for routine medical care, to try and fix your body and wake up trapped in your absolute worst memory. It's devastating to even think about.
It is.
And it really forces us to examine what it is about the surgical environment that triggers this specific response. When you break it down, the operating room mimics the helplessness of an assault in terrifyingly accurate ways.
It mirrors it right down to the baseline physiology. If you listen to survivors of assault, they often describe this sensation of feeling trapped inside their own bodies, completely unable to move or fight back.
But a paralysis.
Exactly. It's a reflexive, paralyzed survival posture called tonic immobility. It's an evolutionary response. And it happens much more frequently and severely in childhood sexual abuse than in almost any other type of trauma, like, say, surviving a car accident.
Right.
And crucially, there's a very strong clinical link between having experienced that tonic immobility during the assault and developing severe PTSD later in life.
So think about this from the patient's perspective. You take someone whose nervous system is already hardwired for that paralysis. Then you put them in a highly vulnerable surgical position.
Right, like the lithotomy position.
Yeah, exactly, where the patient's legs are placed in stirrups. You might be inserting urinary catheters. Or consider a procedure like an endometrial ablation, where the cervix is mechanically dilated. The research points out that this physical dilation causes prolonged pelvic contractions.
And these aren't normal contractions, right?
No, they can last 50 times longer than a standard muscle contraction.
50 times. That prolonged duration happens because calcium very slowly enters the single unit smooth muscle cells of the uterus, creating this sustained cramping tension.
So imagine your body experiencing those slow, continuous pelvic contractions. You're unable to move, completely vulnerable, surrounded by strangers touching you. It's a one-to-one recreation of the tonic immobility they experienced during their trauma.
It really is.
But wait, I have to stop here because there's a massive logical gap that I think any listener would be wondering about right now.
Okay, what's that?
If the patient is under general anesthesia, if they are knocked out cold, how does the body even know it's in a vulnerable position? How does it know it's being triggered? Doesn't anesthesia completely pull the plug on your awareness?
Yeah, so that assumption is exactly where the science takes a very unsettling turn.
Oh boy.
The idea that anesthesia is an off switch is what we call the myth of total unconsciousness. The reality is something termed connected consciousness.
Connected consciousness.
Yeah. Even when a patient appears fully unconscious, paralyzed on the table, and lacks any explicit conscious memory of the surgery afterward, the brain is still actively receiving, processing, and reacting to environmental threats.
Let's slow down and really unpack this, because the idea that you're somehow still awake or perceiving things while under heavy anesthesia is terrifying. How do we know the brain is still listening?
To understand this, let's look at a landmark experiment from 1965 known as the Levinson study. Researchers took 10 dental patients and placed them under deep, verified general anesthesia.
Verified, so they were definitely under.
Absolutely. They were hooked up to EEG machines to confirm they were completely under. While they were entirely unresponsive, the anesthetist intentionally faked a severe medical emergency.
Wait, really?
Yeah. He announced to the room, "Just a moment. I don't like the patient's color. Much too blue." His lips are very blue. He then performed the physical action of administering emergency oxygen and finally said, "There, that's better now."
And the patients showed no reaction in the chair.
None. The surgery finished. A month later, the researchers made absolutely sure that no hospital staff had spoken to the patients about the stunt. They interviewed the patients, and not a single one consciously remembered the surgery or the fake emergency.
Okay.
But then, the researchers placed those same patients under hypnosis to access subconscious memory. Under hypnosis, 4 out of the 10 patients recited the anesthetist's exact words back to him.
They repeated the fake emergency word for word.
Word for word. And it gets worse. 4 others didn't remember the exact words, but they remembered hearing panicked voices and feeling an overwhelming sense of intense anxiety.
Oh my God.
In fact, their anxiety was so severe that they spontaneously woke up from the hypnosis crying in distress.
It completely shatters the illusion of what it means to be under. And you said there's modern data to back this up too, right? Not just studies from the 60s?
Oh, much more recent data. Take a modern cardiac bypass study. Patients were placed on the bypass machine under deep general anesthesia. The surgical team played an audio recording through headphones.
While they were under.
While they were under. The recording simply instructed the patients to touch their chin during a post-surgery interview later that week.
And their brains absorbed the command while they were unconscious.
Yeah. During the post-operative interviews days later, the patients who had been played the recording touched their chins at significantly higher rates than the control group.
That is wild.
When asked why they did it, they had no idea. They had zero conscious memory of ever hearing the audio. But the most striking evidence comes from a recent international study testing connected consciousness directly. They asked patients who were intubated under general anesthesia with a breathing tube to squeeze the researcher's hand on command. 13% of the female patients actually did it. They squeezed the hand.
13%. So the brain is absolutely still listening. It's feeling the environment. And if you're a trauma survivor, your brain is perceiving those vulnerable surgical positions, the intimate touches, the loss of control as an immediate life-threatening attack, even if you wake up and never consciously remember it.
Exactly. And that perception of a threat is where the physical damage begins. Because the brain believes it's under attack, it initiates a massive physiological cascade.
Yeah.
This hidden stress isn't just a fleeting feeling, it causes a tangible chemical storm in the body.
Right.
And we need to understand this storm to see why the standard medications doctors use are actually making the trauma profoundly worse.
Okay, let's talk about the stress storm. What exactly is happening in the brain while the patient is lying there?
When that trauma memory is subconsciously reactivated, the brain's hypothalamic pituitary adrenal axis kicks into overdrive.
Yeah.
The brain floods the system with the stress hormone cortisol. But more importantly, it dumps a massive amount of a highly potent excitatory neurotransmitter called glutamate.
Okay, I want to make sure I'm visualizing this correctly. Glutamate is normally a good thing, right? It's the chemical that helps neurons talk to each other. It's like the accelerator pedal for the brain.
Right.
But in this scenario, it's like a brick gets dropped on the accelerator pedal and the engine just starts over-revving until it catches fire.
That is a highly accurate way to look at it. The brain dumps vast amounts of glutamate, way more than it can safely process or reabsorb. This toxic overflow of glutamate rushes to bind to the specific receptors on your cells called NMDA receptors.
And what happens when those NMDA receptors get hammered by all this glutamate?
They act like floodgates. When they get overloaded, they rip open and allow toxic amounts of calcium to rush into the cells.
Yikes.
Yeah, and this isn't just uncomfortable for the patient. This calcium influx causes irreversible structural cellular damage. It literally destroys dendritic spines, which are the delicate little branches on your neurons that allow them to communicate and form memories.
So the psychological trauma of the surgery is quite literally causing physical brain damage in real time.
It is physically altering the brain architecture. We can actually see this in MRI studies. If you look at the mean hippocampal volume, the hippocampus being the critical memory center of the brain, it's actually 19% smaller in survivors of childhood sexual abuse who develop PTSD compared to those who haven't.
19% smaller. That's massive.
The chronic stress storms literally shrink the brain. Furthermore, this toxic calcium flood amplifies something called central sensitization. In plain English, it rewires the nervous system to be hypersensitive to pain.
Right, so the patient is going to wake up experiencing significantly worse physical postoperative pain than someone without trauma.
Exactly.
Which brings us to a massive problem in how we currently practice medicine. Let's think back to our refugee case study. She wakes up, she's thrashing around, screaming, trapped in an emergence agitation state. The standard protocol for a doctor or nurse seeing a terrified, combative patient is to reach for a sedative, right?
Right?
They want to calm the patient down, so they usually inject midazolam, which is a common benzodiazepine, but you're saying this is the exact wrong thing to do.
Yes. For a patient with severe PTSD, midazolam is a profound systemic misfire. To understand why, you have to look at the altered brain chemistry of a trauma survivor. Brain imaging reveals that patients with chronic PTSD actually have fewer benzodiazepine receptors in their prefrontal cortex, or the receptors they do have are structurally altered.
So if the drug is the key and the receptor is the lock, the PTSD brain has physically changed the locks.
That's a great way to put it.
The midazolam doesn't have the proper hardware to bind to.
It doesn't bind effectively to calm the nervous system, but it does something far worse. Because of those altered pathways, the midazolam ends up lowering the patient's threshold for dissociative experiences.
Oh, wow. So instead of bringing them back to the reality of the safe hospital room, it actively pushes them further out of reality. It traps them deeper inside the hallucination of their assault.
Yeah, you're essentially pouring gasoline on the fire of their emergence agitation. In the case of the refugee, the medical staff did exactly what they were trained to do. As her distress escalated, they pushed midazolam, and it only amplified her terror and her combativeness.
That's awful.
The very medicine meant to rescue her from her panic locked her deeper inside it.
This feels like a massive catch-22. The patient's brain is secretly perceiving a threat. It triggers a toxic calcium flood that shrinks the memory center, and the standard sedative we use to wake them up safely just fuels the nightmare.
Right.
If standard medicine is actively making the trauma worse, what tool do anesthesiologists actually have left to stop this damage?
Well, this brings us to the core of the new research, and the solution is a surprising one. It requires a complete paradigm shift away from traditional sedatives and toward ketamine.
Ketamine.
Yeah. In this specific context, ketamine acts as a highly specialized circuit breaker for the traumatized brain.
A circuit breaker. So how does it stop that toxic electrical surge of calcium from burning the house down?
It goes straight to the source, those NMDA floodgates we talked about.
Yeah.
Ketamine chemically blocks the NMDA receptors located on inhibitory neurons.
Let me pause you there, because that sounds a bit counterintuitive. Inhibitory neurons act like the brain's brake pedals. Why would we want a drug that blocks the brakes?
It's a brilliant mechanism, actually. By temporarily blocking those specific brake pedals, ketamine forces the brain into a state of disinhibition. This sparks a sudden but completely safe release of glutamate.
Okay.
But here's the magic trick. Because ketamine is currently blocking the toxic NMDA receptors, this new wave of glutamate has nowhere to go except to stimulate a completely different set of receptors, known as AMPA receptors.
And we want the AMPA receptors stimulated.
We absolutely want them stimulated. Activating AMPA receptors triggers the release of critical growth proteins in the brain. You might see them in the research as mTOR and BDNF.
Let's translate that alphabet soup for a second. Think of these proteins as the brain's general contractors and fertilizer.
I like that.
When you do aerobic exercise, your body naturally produces BDNF, which acts like Miracle-Gro for your hippocampus, helping to build new pathways and protect against cognitive decline. You're saying ketamine triggers that exact same neurofertilizer, but chemically, while the patient is asleep.
That is a perfect analogy. It promotes rapid synaptic plasticity. It physically helps the brain grow new dendritic spines, replacing the ones destroyed by the stress storm, and it improves connectivity in the prefrontal cortex.
Wow.
So ketamine isn't just acting as a shield, it's actively forcing the brain to heal itself while simultaneously protecting it from the stress of the surgical environment.
Okay, I love the biochemistry here, but I have to push back hard on this.
Sure.
Because if you ask anyone on the street what ketamine is, they will tell you it's a dissociative hallucinogen. It's famous for putting people into a K-hole where they completely detach from reality.
Right. Yeah.
If a sexual assault survivor's primary psychological defense mechanism was to dissociate to float outside their body during the attack to survive, it isn't giving them a drug famous for causing dissociation incredibly reckless. Aren't you just chemically forcing them into their trauma response?
That is the single most important question any clinician or patient should be asking.
Okay.
And the answer, it entirely comes down to the concept of dosing.
Okay, dose.
We are not talking about giving a full anesthetic dose that knocks someone out. And we certainly aren't talking about recreational doses that cause a dissociative K-hole. The protocol here relies on a highly specific subanesthetic microdose.
What does a subanesthetic dose look like in practice?
We're talking about a dose of less than 0.5 milligrams per kilogram of body weight. At its extremely low concentration, ketamine simply does not cause dissociation.
Not at all.
No, it doesn't cause hallucinations, and it doesn't impair cognition. It stays below that threshold. Instead, at this micro level, it acts as a profound analgesic. It dulls that central sensitization we mentioned earlier, which stops chronic, amplified pain from taking root. And just as crucially, at this low dose, it acts as a powerful anti-inflammatory.
That connects to a huge, often overlooked piece of the PTSD puzzle. Because trauma isn't just in your head, it lives in your immune system. PTSD is inherently a pro-inflammatory state, isn't it?
Heavily pro-inflammatory.
Yeah.
Patients with severe trauma essentially have chemical fire alarms ringing in their bodies 24/7.
Right.
These alarms are inflammatory cytokines. You'll see them labeled in blood work as IL-1 beta, IL-6, and TNF-alpha. Because these alarms never shut off, trauma survivors, especially females, and military personnel with sexual trauma histories are 2 to 3 times more likely to develop severe autoimmune conditions later in life.
That is terrifying.
Their immune system gets so exhausted from the constant false alarms that it starts attacking healthy tissue.
And the subanesthetic ketamine shuts off the fire alarms.
It quiets the microglial cells in the hippocampus, which are the cells responsible for manufacturing those cytokines. It dramatically drops systemic inflammation in the nervous system, but it leaves the rest of the immune system perfectly intact so the patient can still physically heal from the surgical incisions.
So, to summarize this, at a carefully controlled microdose, you get the circuit breaker effect that stops brain damage. You get the release of fertilizer that rebuilds neural pathways. You stop the amplification of post-op pain, and you extinguish the inflammatory fire alarms. And you do all of this without causing the patient to dissociate. I mean, it almost sounds too good to be true.
The biochemistry is incredibly elegant, but we must stay grounded. Ketamine is a powerful tool, but it's not a magic bullet, and it is strictly not for everyone.
What are the medical boundaries? Like, if I'm a patient listening to this, how do I know if I'm disqualified from this approach?
There are strict contraindications. It must be avoided in patients with a history of ketamine-related uropathy. We know that long-term ketamine use or misuse can cause severe, painful bladder issues and urinary urgency.
Right, so anyone with a history there should not receive it.
Exactly. It's also strongly contraindicated for patients diagnosed with schizophrenia, patients with poor liver function, those with significant uncontrolled hypertension, or anyone who is currently pregnant or breastfeeding.
Which really highlights a larger point. You can't just inject a chemical, cross your fingers, and ignore the room. True healing requires more than just pulling the right vial off a pharmacy shelf. A pharmaceutical solution is ultimately only as good as the human care surrounding it. For trauma survivors, this requires a deeply holistic, trauma-informed approach.
I couldn't agree more. You could administer the absolute perfect subanesthetic dose of ketamine, but if the physical environment of the recovery room is aggressively triggering, you're still actively harming that patient.
What does trauma-informed care actually look like in practice, beyond the IV drip?
It requires a culture of situational hyper-awareness from the medical staff. It means doing simple but profound things, like intentionally turning down or muting loud, jarring monitor and ventilator alarms before the patient wakes up.
Oh, that makes sense.
It means dimming the harsh fluorescent hospital lighting to create a calmer sensory environment.
I imagine it also requires a profound shift in how the staff physically interacts with the patient's body while they're vulnerable.
Yes. It requires clinicians to be incredibly communicative and explicitly gentle regarding intimate touch, explaining what's going to happen before inserting a urinary catheter, for instance. But it also requires an awareness of interpersonal triggers.
Interpersonal triggers.
Yeah, a doctor or a nurse might simply share physical characteristics, a tone of voice, or mannerisms with a patient's past perpetrator. That alone can elicit an uncontrollable trauma response, and the staff needs to be trained to recognize and gracefully adapt to that without taking it personally.
Because that goes right back to the very root of what trauma is. At its core, trauma is the ultimate violent theft of control and safety. So giving a patient agency in the hospital, giving them collaboration, establishing clear physical boundaries, and offering them choices about their own care actually works to restore the control that was violently taken from them in the past.
Choice is everything in trauma recovery. Even offering a patient a choice in their pharmaceutical management empowers them. It shifts them from being a passive victim on a table to an active participant in their healing. It builds safety.
That makes perfect sense.
And the data reflects this beautifully. In broad studies evaluating hospital care, when patients are asked what specific actions make them feel the safest, they don't say the newest technology or the fastest surgery. They consistently rank being listened to by your nurses and doctors as the highest metric of caring behavior.
Just being listened to. It's so simple, yet it completely changes the entire architecture of the medical experience.
It is the foundation that allows tools like ketamine to actually work.
It really leaves you with a profound new paradigm to consider for the future of medicine. Think about it. Before you ever undergo a surgery, the hospital universally checks for physiological allergies.
Always.
They ask you, are you allergic to latex? Will you have a reaction to penicillin? They do this meticulously to prevent your body from going into physical shock. But what if the future of medicine requires us to check for psychological allergies?
Yeah.
What if we start routinely screening for trauma as a standard vital sign so we can tailor anesthesia to protect the mind just as fiercely as we protect the body?
If we adopt that standard and look at a patient's trauma history as a critical vital sign, we could entirely prevent these devastating brain stress storms before they even begin.
For survivors of trauma, undergoing surgery shouldn't mean reliving past pain, and choosing the right anesthetic can make all the difference in feeling safe.
Absolutely. By understanding the unique brain chemistry of PTSD, clinicians can use targeted tools like low-dose ketamine to protect patients when they are most vulnerable.
A powerful step toward truly compassionate care. Thanks for listening to the Talking Ketamine podcast. We'll catch you on the next one.